They're also considering doing other diseases apart from mesenchymal, apart from graft-versus-host disease, including Crohn's disease and mesenchymal stem cells for transplantation. So we eagerly await your catch-up.
Thanks very much, Robert. Looking around this room, probably oldest, I'm sure I'm the oldest person here, so I've got a long background in clinical haematology, particularly bone marrow transplantation. Stuart's reference to David Haylock and others reminded me of the dramatic first peripheral blood stem cell transplant that was carried out in Adelaide, Australia, and reported in the Lancet in 1985. It was really groundbreaking research. And here's the picture that haematologists like to show their students. If you look at the bottom, we see the mature cells in the blood, red cells, platelets, macrophages, and all the white cells. They all come from a pluripotent stem cell, including our immune system to the lymphoid stem cells. In the bone marrow, we have a rare cell called the mesenchymal stem or stromal cell, which has very important functions in terms of maintaining the hemopoietic stem cell. It tends to keep it in G0, inactive until it's required. It's also very important in maintenance of other tissues such as bone, cartilage, and fat, which is how these cells are often defined. They can be isolated from many tissues. They adhere to plastic, which is a very simple way of isolating them. In fact, in cytogenetic cultures, if you keep the cultures going too long, these cells overtake the tissue culture plate and they're considered a damn nuisance. They regulate hematopoiesis, they've got regenerative and repair issues, which is important perhaps in clinical applications, I'll mention later on. One of their very important characteristics is they have homing receptors, they express chemokine receptors, and they will track to areas of inflammation and work at the site where they're required. They can develop immunosuppressive T regulatory cells, and that's also an important implication of clinical trial work. Here we see cells being grown in what we call factories, large tissue culture plates, and these cells are replicated and they're passaged when they reach confluence, up to 5 or so passages. And there's a thin film on that plastic that you probably can't see, representing the cells which have to be taken off that, which is, I guess, why we're needing to think about bioreactors in upscaling the production of these cells. This just shows a picture of these cells with their characteristic fibroblastic morphology. There is no specific marker for these cells, and we define them using with flow cytometry for these various markers, which I won't go into, but to say that the markers of hematopoietic cells at the bottom, 45, 34, 14, they're negative. The differentiation capacity is important, and this again is important in the clinical applications. They can go down the pathway of fat, and of course you can take them from fat. They can go down the pathway to form bone, and bone morphogenic proteins are actually approved by the TGA and marketed, so that orthopedic surgeons are using these bones to improve operations like spinal fusion. Now they can go into the cartilage pathway, important for applications in tendon repair and other similar areas. Now these cells, unlike the cells that Robert was talking about, you have to have each patient with a different HLA type. These cells are very low in the expression of class 1 antigens, and they don't express class 2 antigens. So they are in fact universal donor cells in human. Mouse do express class 2, and this is the important lesson that you can't extrapolate mouse experiments to man in this area without this proviso. How do they work? Still, it's becoming increasingly complex. They work by both soluble factors that they produce and by cell-to-cell contact. The targets are generally cytotoxic T lymphocytes, or THT cells by the cytokine release, and they can produce inflammatory cytokines such as interferon gamma from Th1 cells and turn the pathway from a pro-inflammatory to an anti-inflammatory cytokine profile. And they are protected because of their lack of expression of the HLA markers. So putting them into the human body at a point when there's no inflammatory stimulus means they won't work. So in the case of bone marrow transplantation, you put them in too early, they're not activated, and so you do not see an effect. So just to mention one of the important agents they secrete, which seems not to be effective, that the IDO1 or indolemin 2,3-dioxygenase is produced by these cells, and it depletes tryptophan to form pyrene. Tryptophan is needed for lymphocyte differentiation, so depletion of tryptophan leads to a lymphoparolytic state, if you will. Just to summarise the therapeutic features of these cells, they handle inflammation, they work where they're needed, they have a reparative function, and they have regulation by the microenvironment, very importantly. This is a diagram that applies to quite a few inflammatory disease states, particularly autoimmune disease. This specifically refers to Crohn's disease and inflammatory bowel disease, which is an abreaction to the environmental pathogens that we ingest in our gut. And on the left is the pro-inflammatory pattern with nasty cytokines such as interleukin-17A and others produced by these Th17 T cells, including also cytokines produced by the Th1 cells, and importantly, interferon gamma and TNF-alpha and IL-6 tend to activate these cells. What we're trying to achieve is shift the pattern to the right-hand side of the fulcrum and increase the T regulatory cells with their anti-inflammatory patterns. Our first trial was with graft versus host disease. Graft versus host disease is a complex illness after a bone marrow transplant. Bone marrow transplants are generally done for hematological cancers, some other metabolic disorders, etc. And you infuse an HLA-matched marrow or peripheral blood stem cells made to circulate into the peripheral blood. And David Hallock is going to talk more about these cells later on today. You could remove this phenomenon of graft versus host disease by taking out the T lymphocytes from the infused bone marrow. So it will still engraft, albeit a bit more difficultly, but you remove the rationale why bone marrow transplants work. Allogeneic bone marrow transplants work because your foreign immune system is inhibiting the hematologic cancer. Take out the T cells and the cancer recurs. So you can't take out the T cells, as we learned in the late 80s when this was a common procedure. When we do a transplant, we give the patient nasty chemotherapy and or total body radiation. And this has a number of adverse effects. It damages the gut mucosa of the liver, produces these inflammatory cytokines, and causes leakage of lipopolysaccharide from the gut mucosa. This upregulates the host histocompatibility antigens. You get activation and expansion of these donor infused cells in response to that antigen presentation, and the activated T cells expand, produce cytokines, and differentiate into effector cells, and cause tissue damage in the recipient. This is a phase 2 European study published by Catherine LeBlanc and others. And in fact, there was one Australian centre at the Royal Adelaide. The cells were infused after the patient developed steroid refractory graft versus host disease, meaning cortisone type drug refractory. That has a poor prognosis, and generally the survival with steroid refractory graft versus host disease is about 15 to 20%. here on the top blue line is the respondents in this trial, and the survivals, the N was 55, the survivals around about 50%. It's a significantly improved result for the non-responders. We started a phase 1 study at Royal Perth Hospital in 2007, and we aimed to use the dose of cells described there, which was the same as the phase 3 trial being conducted by a commercial company at the same time. The primary objective of this trial was safety. Here are some pictures just to show what graft versus host disease looks like. On the left shows this typical pattern of erythema, of redness of the thenar and hypothenar eminences. On the right is more chronic graft versus host disease. You can see the scaling and there's abnormal pigmentation at the bottom, the depigmentation and the pigmentation. And it also affects the nails. It affects any epithelial tissues. This is probably the worst skin, acute graft versus host disease I've seen. You can see the marked total body erythema and the blister formation, very serious condition mimicking severe burns. Another characteristic is damaging the mucosa in the mouth. You can see the tongue, and as well as the palms, the feet can have this erythema of chronic acute graft versus host disease. Interestingly, this slide is a picture of the liver function test of the person that Stuart showed in his final slide, the young man sitting with glasses, his patient I've been treating for some years. He had refractory acute lymphoblastic leukemia, had a bone marrow transplant in 2007. He's the first patient we treated, and he's alive, doing well. And he admittedly still requires an infusion of mesenchymal stromal cells. GVH under control. But the GVH is preventing the leukemia from recurring. In a type of leukemia that has a very high rate of recurrence. And the arrows at the bottom show when he received infusions of these cells, and on the y-axis you can see his bilirubin, which has responded. His liver function tests are currently normal. I won't go through this slide in detail. This is the type of patients we've treated with acute graft versus host disease. Diagnosis on the left, all the poor prognosis, hematologic malignancies. And the types of organ involvement: skin, gut, liver, and mouth. And the response rate is actually quite high. But the outcome is still not good because the immunosuppression these people have received, part of their transplant, the immunosuppressive drugs, and steroid therapy leads to opportunistic infection, and that's what happens to cause death. Moving on to chronic graft versus host disease, when there's fibrosis as a secondary response, the response is not usually able to be achieved. Here we see a girl with an unusual form of chronic graft versus host disease. This was 8 years after a bone marrow transplant for leukemia. She received mesenchymal stromal cells and her skin responded completely. But it has relapsed later, and she has required further infusion. So I think one of the messages that I've learned is that these cells do not cause permanent effect. Here we see a couple of pictures of chronic graft versus host disease causing dystrophy of the nose, which you can't reverse. And in a few patients we've treated with chronic graft versus host disease, we've had response in some organs, but where there's been fibrosis, there's been no response. And two of the people here have died from progressive graft versus host disease. Here we see our Kaplan-Meier survival curves. The solid line is acute, the dotted line is going out to about 3 years, and survival rate around 50%, which is similar to what we've seen in the European study, but the numbers are small. So, what areas have been covered in clinical trials? I can't possibly cover all this. I did a look on the NIH US site a few days ago, and there are around about 100 odd trials listed in clinicaltrials.gov. It's quite, we can go there, we can go